Yeah.
And the fact is, you know, you end up with a vein that's quite nice. It's like anything else, you have to have people who know how to do it properly, and we're really lucky to have some PAs that do this quite well. I think that's of all the basic things we're talking about today, this is the one that's closest to achieving those ideal characteristics. We can do the same thing to take the radial artery out through a small incision at the wrist, and the process is very similar to what you saw for the vein. So let's skip from bypass surgery and talk about valve surgery. Obviously, we want to do that minimally invasive as well. And there are a lot of things that are coming down the pike now to make that a reality. The advantages are similar in that reduce pain, reduce recovery time, reduce blood loss. The potential advantages are the same as we talked about before, where there's increased cardiopulmonary bypass time, at least initially, and there's a learning curve to all these procedures. As before, not everybody is appropriate to undergo a minimally invasive valve procedure. People who have really calcified aortas, people who've had previous umbrellas for blood clots coming from their legs to their lungs aren't appropriate for it. People with aneurysms. There's just a number of things that might keep somebody from being a candidate for it. Initially, we tried this doing what's called port access surgery, and you guys may or may not remember, but some years ago, this was really popularized at Stanford University, and basically it involved a small chest incision, and then the cannulas, the heart-lung machine, placed through the neck and through the groin, through the femoral artery and vein in the leg, and there was catheters that were placed within the heart to deliver a solution that would stop the heart and keep it cold and protect it. And there was a balloon that was threaded up the aorta to occlude the aorta, so you didn't have to put an actual clamp on there. And this procedure seemed like it was going to be a really big deal. Unfortunately, there were some problems that people encountered particularly with this balloon, where some of the aortas were dissecting. The inner surface was dissecting from the outer surface, and they had some early deaths in this. And the FDA actually pulled the whole system off the market for a while. And then scientists redeveloped the balloon and made a lot of modifications. And so a lot of the things that we learned back in that time about minimally invasive surgery and these types of cannulas, those lessons have been learned and now reapplied in better technology with better results. And then of course everybody's heard about the robot. I first worked with the robot in Germany, about 10 years or so ago. And this is a picture of a typical robotic setup. And the thing I think you first notice is that the patient would be here. The robot is incredible. I mean, it's humongous. And then the surgeon would be sitting at the console completely away from the robot. And this console can even be in another room. For those who aren't aware, the whole robotic idea actually came from the military. And the idea was that if we could get surgeons who were highly trained, who were away from the front lines, to actually perform surgery at the front, without having to have a surgeon actually there, you'd have some assistant, put the person in the robot, and then the actual surgeon could be miles away, looking at a screen, directing the robot's hands. Well, that was the whole idea for this. And they have actually done, I know they've done gallbladder operations and stuff with a robot where, the person was across the sea. So the idea was a real thing, and it did have applications. So it's a super cool idea, but as you can imagine, it has some disadvantages. When I first saw it in Leipzig a few years ago, they were doing a very simple case, and they ran into some problems, and the patient ended up with 5 ports for the robot, plus another incision to open the chest, plus a medium sternotomy. So, it wasn't ready for prime time then. And in fact, one of my good buddies in 2003, Ralph Damiano, made this statement. At that time, well, in 2003, which is 5 or 6 years later, that there was little clinical value added by the use of the robot. That's not true now. I mean, the robot in certain circumstances is very useful, and in very experienced hands and people who are very well trained, you can get very good results from the robot now, but not everywhere and not all the time for all situations. So the robot not only, as I mentioned before, requires a lot of extra technical expertise and a lot of money. It's a $2 million investment to have a robot, and we have yet to prove in cardiac surgery that it has major advantages. For a while we thought it had major advantages in prostate surgery. I think it probably does. There are some papers that have questioned that, but I think in GYN surgery, urology surgery is sort of state of the art right now, but it's still working its way through cardiac before we get to the point where we can really declare it a success. In the meantime, we've worked on a lot of other ways to try to accomplish the same goal without having to have a robot doing it. Still having a person, and obviously the person is directing the robot. The robot doesn't really do the surgery, it's the person directing it, but to have it more in our own hands. And there are a couple of very nice techniques that are developed. One is a partial sternotomy, and the other is another small thoracotomy. And here's a mitral valve replacement being done through a small thoracotomy. And this is the view that a surgeon can get, particularly in a patient who's not too large, of the mitral valve. And here you see the valve being implanted, and the incision is not much bigger than the valve itself. Here's a guy that I did a mitral valve replacement on, and I used the small upper incision. Now, I don't know if you guys can probably see this incision. It's a very small incision, and there's no other ports. There's a chest tube site here, and there's no other incision on this guy's chest. A robot can't beat that from a cosmetic standpoint. This guy did very well. Here is the standard robot setup, and with the robot you have a small incision here that you're operating through, but you've got 5 other ports where the camera and instrumentations and whatnot are going through. And this is a minimally invasive mitral that we can do. And we do this with a small incision here, and all we've got is we have a small incision down in the groin that you don't see, which you also have for this, where the cannulas are placed in the groin. And you have a chest tube site, and so all you've got is this and this. And that's without using a robot. So it's hard to argue that this is really better than that. As I mentioned before, what neither one of those pictures shows is that also we have a tiny incision down in the groin where there's a cannula going into the artery and a cannula going into the vein to place the person on the heart-lung machine. This is an elderly lady that was in her late 80s. She had bad aortic stenosis. She had had a previous pacemaker years before, and she had an autoimmune disorder that required her to be on high-dose steroids. So she's the type of person that has a very high likelihood of not healing a sternotomy. If you cut through the bone, at her age, she's going to have osteoporosis, which can interfere with healing sometimes. And with her being on steroids, most of you probably noticed, steroids can impair healing, can increase the risk of infection. And so I really did not want to do her through a standard sternotomy. So we chose to use this approach, and you can see this is her incision here for an aortic valve replacement. And that was a real advantage for her, because she would have quite a different experience trying to heal the bone. But she had all the other criteria that are necessary to suggest that she would be appropriate for that type of procedure. Lamella's law is a nice thing that I heard. Joe Lamelas is he's a surgeon, excellent surgeon down in Miami. And he actually is the one I learned how to do the techniques that you've seen in the previous slide. And Lamella, he has a formula here where the patient trauma, which means the amount of incision, the technical difficulty is inversely proportional to the patient trauma. And that is that the smaller incision that you make, The harder the operation is for the surgeon. Pure and simple. So a surgeon has to be aware of that and has to be realistic when he offers that procedure to someone, that he can get that done safely, and that it's going to be a major advantage for that person, because it is going to be, by definition, harder. That's just the way it is nowadays. So, for minimally invasive cardiac surgery, pros are more cosmetic, less wound complications, potentially faster recovery. The cons are it's technically more complicated, not applicable to everybody, and there's an increased risk for major complications in certain situations. And so a surgeon, as I say, has got to really pay attention to that. So the bottom line for all this is that every patient needs to discuss with their surgeon the risks and the benefits for them for a minimally invasive procedure before they come saying, oh, well, I read on the internet you can do this, and I really want to have such and such procedure. You got to discuss what the pros and the cons are, and then make the decision. And you make that decision with a surgeon who's not out to sell you something other than the best procedure for your particular situation. So that's it.